Good morning, everybody. John Harris here, managing partner with Fortune Management. I have the pleasure and honor to speak with my good friend Hootan this morning with Code Medical Billing. He supports a lot of our clients around the country with medical billing integration, tapping into some of those lost opportunities to generate more revenue without necessarily seeing more patients. And then ultimately, one of the things that we've talked about in the past is the top two things, well, the three things that all consumers want, especially dental patients, is they want to spend less money, they want to save more time, and they want to experience less pain. And that's what we're seeing more and more of. So the practices that I'm seeing that are more have positioned themselves more on the cutting edge of technology and are really able to tap into a lot of the opportunity and success, financial success anyway, that's available with the trends taking place in the industry, are those people that are more progressive with technology, more progressive with anesthesia, and more progressive with finding creative ways to make treatment more affordable, and medical billing is an option to do that. So I wanted to get him on the in a meeting this morning, have a little casual conversation about medical billing, what the opportunities are, and the vast majority of dental practices out there, how his organization can help. And then also just kind of get some insight as to with his particular area of expertise, where he sees the industry going, and where he believes the opportunities are going to be in the next 2, 3, 4, 5 years, so that our folks or anybody watching this will have the opportunity to have that information in advance, and then go ahead and make some executive CEO type decisions to position practice for success in the future. So with that, I'd like to introduce Mr. Hootan Shahidi with Code Medical Billing. How are you, man?
Good morning, brother. Thanks, John. Thank you for having me, and always good to see you. Haven't seen you for a couple months, so this is nice.
Yeah, I got my Hootan haircut on this morning.
You don't have your Hootan goatee, though.
Yeah, I don't have that out just yet. That's more my wintertime look.
All right, gotcha.
So cool, man. So if you wouldn't mind, just kind of give us some insight. Tell us about Code. Tell us about how you got into it. What it is specifically that you do, how you help dental practices across the country, and what your range of services, quote unquote, would be.
So we're a full-service medical billing company, and I know that's not necessarily familiar to most of dentistry. Still to this day, I would say, nationally speaking, probably less than 10 or 15% of dentists utilize medical billing consistently. And so it's very normal on the physician side. So what we provide are basically four things for dentists to bill medical, and that's going to be benefit checks. This would be us finding out the deductible, the out-of-pocket maximum, whether a pre-auth is needed or not. Then we do pre-auths. That would be the second step, and an important one, especially for sleep offices. The third is obviously get the claim out. And then the fourth step, if needed, obviously we will fight and appeal those claims that have a fight or are able to be appealed as well. So that's pretty much the four steps that we do. And then what we built in medical is full room. So I think our company has a number of competitors, but they only do 2 or 3 codes, and those would be the sleep codes. We actually do it all. We do cone beam, oral surgery, perio surgery, trauma. So the whole magnitude of what you can do from dental to medical.
That's a common question that I get a lot of times, because I'm always talking to my guys about, medical billing, implant placement, providing more services under one roof, whether that be more of a super GP oriented practice, or if it's a multi-provider, multi-specialty type practice. But the ability to provide more services under one roof is very appealing to dental consumers. Additionally, is the more options that you have to make treatment more affordable is very appealing to dental consumers. And so one of the questions that I get when I talk about medical billing with a lot of my clients is, well, I heard that, it's only a couple of codes that fall under medical that you can even get reimbursed for. Or I've heard that we've tried it, back in the day, we tried it. We used to do a little bit of it, and we didn't have a lot of success with it. Or, we don't provide a lot of services that fall under that umbrella. So can you walk through, you don't have to give all of it, but could you walk through like the most common procedures that you see that you're filing under medical insurance and having success getting reimbursed?
By far, one of the most predictable and successful by a long shot are going to be the sleep appliances. So the mandibular advancement devices to manage sleep apnea. Those have the highest success rate and by far the most predictable. So those go through real easy. I would like to say, since it's almost June now, this is a particularly great time for trauma. Trauma is very successful through medical as well. And the reason I say now, unfortunately, June, July, August, we see a lot of teenagers, football, basketball, karate, soccer, various water activities. So, they might get hit in the face in a game. They might take an accidental elbow. So as a company, we actually see a huge spike in trauma from about June through August. So that's something to think about as well for a lot of our dentists who may be listening, that, getting an elbow in a pickup basketball game is trauma. The face with baseball is trauma. Anything of that nature is trauma, and so that would be billable to medical. Aside from trauma and sleep, what we're sending a ton of is we send a ton of CBCT. That's probably upwards of over 1,000 a month of just those claims. We send a ton of grafts and membranes. So this would be sinus lifts, membranes for a variety of different perio and oral surgery procedures as well. And then from there, probably on the lower level, we do submit a number of exams per month, a number of two-dimensional x-rays like bite wings, PAs, panos, things like that. And one thing that we've definitely seen with remarkable rise over the last 2-3 years is going to be frenectomies, particularly tongue ties for infants. That's probably had as much growth as sleep has for us in the last 2-3 years. We probably now are billing those a few hundred times a month, whereas 4 years ago, I don't even know if we billed it 15 times a month.
Cool. I like it. And you mentioned CBCT. So from what I understand, one of the big reasons for the rise in medical insurance was there was I don't know, this is just a story I heard. There's a doctor way back in the day that had bought CBCT in a dental practice, and he's wanting to figure out how to get paid for it. So I typically see two different approaches to getting compensated for a CBCT through insurance. One is to, and this is not recommended, but to file the CBCT. Obviously, you've got a pano kind of built into that, and so you're filing that you're actually doing the CBCT and you're filing the 130. And to my understanding, that's not technically kosher. That's not necessarily something that you want to do. I've just seen that as an approach to getting reimbursed.
Some of the machines, depending on the sensor of the machine, not necessarily, but some of them don't, in fact, render a true panel. The field of view is simply not large enough. So yeah, D0330 would not be appropriate. And even if it were, I mean, are you doing that in other places? Do you do a crown and bill it as a 3-surface composite? Do you do 4 quads therapy and bill it as a prophy? Do you, there's a lot of different places I bring up examples, but do you downgrade yourself in other places? Usually the answer is no. And in this case, a brand new pano is like 30 grand, a brand new CBCT is like 120 grand. I mean, that one just doesn't make sense on any level. Mm-hmm. I get it. I get it, even though I disagree with it.
Yeah. Oh, yeah. And I certainly not making that recommendation. I'm simply saying that I've seen this is an approach that a lot of doctors, I'd probably say the vast majority of dentists across the country, is how they're getting reimbursed for their CBCT, which technically is going to be in violation of their contract with their insurance company in a lot of cases. And so the appropriate approach to getting reimbursed for that CBCT would be to file through medical insurance. And then obviously if you file under medical insurance, you're getting reimbursed at the CBCT rate, not a D0330. Is that right?
Correct.
Okay. And so for that reason, I see a huge opportunity just from, because I would say that the CBCT code, the reimbursement's at least twice that of a PAN, at least from what I've seen. And so I think that the opportunity for generation of revenue right there without necessarily seeing more patients is tremendous. Okay, good. Let's see. And then you mentioned exams. What kind of success rate are you seeing? What kind of success rate are you seeing with exams? Because I'm
incredibly high.
Knowledge. Go ahead. I was just going to say, with my limited knowledge, I've been to your courses before, and I've heard you say that, you know, these are the things that typically fall under medical insurance, and I take that and I say, you know, virtually anything diagnostic in nature could theoretically fall under medical insurance. You could potentially get reimbursed for that, whether it's exams, whether it's diagnostic technology like CBCT or a PAN. What kind of success rate are you seeing, and what percentage of your dentists are you seeing that are really taking advantage of filing those codes under medical?
The exams are unbelievably successful. They tend to go through at a very high rate as well. The thing with the exams is because the value itself that you're billing is not very high. As in, the exam could be anywhere from $20 to $200, depending on what kind of exam you did. There is an argument, which I know a lot of dentists make, that, people's deductibles are high and it's only going to go towards the deductible and what have you. So there's no point in me doing it. The reason I disagree with that is, unless you specifically know that patient's deductible, you're wrong. That's the first issue. The second issue is that if you are a comprehensive dentist and you're going to be seeing this patient X number of times in that year for whatever surgery you're doing or for managing their sleep apnea, wouldn't you want to burn through that deductible, not only to help your patient from a customer service, patient centricity side, but eventually if you and maybe some other healthcare providers or just you yourself get through that deductible and now you start moving into getting payments, well, wouldn't you want to do that as well? And unfortunately, John, kind of what we're dealing with, you and I both, is that even though dental insurance has been $1,500 for 47 years or so now, it's created an addiction of, I will get paid immediately, no questions asked. And that addiction is hard for me to get around. Whereas, if you look at the medical model, they could care less what the deductibles are because I provided you a service, you're going to pay. Whereas in dentistry, it's like, oh, well, I don't want to get a bad Yelp review. I'll waive this. Oh, I don't want them to put this on Google. I'll waive that. So I'll destroy my business on the possible theoretical chance that somebody might complain. Again, those are two different models, but no doubt dental insurance is, I'll pay you for your pro fees 2 times a year in 7 days, has created an unbelievable mindset.
Mm-hmm. Yeah, you mentioned an interesting thing there too when you said deductible. Are you finding that folks are having more success filing medical during the second part of the year versus the first part of the year because their deductible is more likely to be met at that point? What are you seeing there?
Sure. So statistically speaking, as the year goes by, things happen and people start going to the doctor for whatever, cold, sickness, flu, checkups, so yes, October, November, December is by far the best months to submit. January, February is probably the worst to submit. And this might clue you in a little bit in your personal life on, you might go get a lab test or you might go to a clinic or something, and 2 or 3 months later, they send you the bill. And a lot of times, maybe from our dental perspective, we might say something like, oh my God, that lab, they're so disorganized, they're so lazy. No, not really. There was a reason why your bill arrived 3 months later or 4 months later, because they didn't bill your insurance the day they saw you. Mm-hmm. They waited a few weeks, 3 weeks, 4 weeks, 5 weeks, whatever, and then batched them out one night, simply because they too are well aware of this data. And so they're playing the same statistical game.
I got you. It's interesting that you mentioned that. I recently had some blood work done from recommended by my coach. And when I think, I can't remember when I had it done. I had it done, I don't know, probably 3 or 4 months before I got a bill in the mail for $19.95. And I wrote my credit card information on there, my debit card information on there, and I sent it back. And then another month goes by and I get it back in the mail and they say they can't read my writing. So I wrote it again and I sent it back to them. And then another month goes by and they sent it back to me. And they said, we still can't read your writing. So finally, I felt like, just giving them a hard time with it. They were stamping like second attempt, third attempt, and trying to make it look like I wasn't trying to pay them. Finally, I just cut them a check so I could wipe my hands of it. But there was a part of me that just kind of wanted to drag this process out, try to get them back for delaying this. But yeah, I can certainly appreciate that. Let's see, from a practice growth standpoint. So a lot of our practices, obviously we're always looking for opportunities to grow. You've got a lot of dentists out there purchase a practice so that they've got a job, and then a lot of dentists out there purchase a practice because they want a tangible asset that they can grow, over a period of years, and then hopefully sell that asset and get a return on investment. Not to mention pay them, income along the way. So we're always looking for opportunities in the practice to grow, whether it's organically or non-organically, artificial growth. And so in terms of return on investment, what would you say that you see just from a raw growth? And I know you can't give a specific number because I'm sure it's all over the board, but if you had to pick an average, on average, what would you say that the typical practice grows when they start to implement medical insurance?
Real quick, so when you say typical, are we saying that they have CBCT, do some oral surgery, do some sleep, or when you say typical, do you mean something else?
Well, let's say all the above, and then let's look at how does the practice that doesn't have CBCT, that's not placing implants, that's just your 65, 70-year-old dentist, out of date practice that has no technology, what's their potential versus the guy that's placing implants, doing sinus lifts, has CBCT, what's the growth potential?
So we'll go low versus high. On the low end, if it's a mainly restorative practice with predominantly 2D technology, I'm basically going to be stuck on exams in 2D claims with the occasional trauma that walks in. And even then, when that occasional trauma walks in, if it's like, an anterior extraction bone graft membrane implant abutment crown, my client may not be doing anything except for the abutment crown. So even that is significantly diminished. So that would be, very low. I don't even know if you would hit 1 or 2% growth. Now, if you have CBCT, you do a lot of your own oral surgery, and you are pretty good at doing, let's say, a low conservative number, like 1 to 4 sleep appliances a month, then it's very reasonable for you to do 10% with not too much effort. If you have a very solid workflow, then you're talking about 20%. So let's say if you are collecting $1 million, it's very reasonable to add another 100 or 200 grand if you're doing all of that stuff. And certainly sleep would be one of the more helpful ones to get to that target. But let's just take sleep out. 10% is a very realistic number for a decent workflow. So if you're doing $1 million, you have cone beam, you do oral surgery, not necessarily a lot of sleep. Adding another 100 grand in revenue, so about $8 grand a month, is a very reasonable number.
Okay. You mentioned workflow. What would you say are the biggest distinctions someone can make with regards to their workflow to improve efficiency? And so, for example, if they've got, a mediocre workflow versus an advanced workflow, what are some of the distinctions that differentiate between mediocre and advanced?
What I'm referring to as mediocre versus advanced or low is basically by the number of claims that, let's say, I see in my server monthly, right? Now, then when you get into those, because I'm friends with various people who have these various workflows, all of the advanced workflow people all have a built-in system where the notes are already in terms of like a library. They have templates. It's all written in a medical necessity format. They're very familiar with the ICD-10 language, so if they need to tweak it, And so as a result, rather than, let's say, writing an original document every time that's very time consuming, they're working out these medical documents chairside with their assistant because it's already in EagleSoft or Dentrix or Open Dental. It's ready to go. So at the day or at the end of the week, when the office manager wants to submit, let's say 50, 60, 70 claims, it's a piece of cake. It's just copy and paste, drop it into our system, you're done. When an office doesn't have a workflow or doesn't have that template system in place, or hasn't really communicated to the front and the back office what things are going to be sent to medical, then it might take the office at the end of 1 week double or triple the amount of time to submit 1/10 the number of claims. So 70 claims was sent out by Office X inside of 1 hour by the office manager. Office Y for 10 claims took like 4 hours. So that's a big gap. So it's just like everything else, John. You probably, I'm sure you go to offices where, they use the CEREC 10 times a month, and then you go to offices where they use it 150 times a month. You ask yourself, what's the difference here? It's not too different than what I'm saying. One has a system, and the other doesn't. One way of doing things, and the assistants do a lot of the work, and it's team driven. The other one, the doctor will stay at night and do the staining and glazing. And it's just these bizarre things that you see. And as much as you try to help it, sometimes it is there. And something that, myself, I work on a lot with our clients when they call for support. We also do a number of one-day courses around the country, which are open to our existing clients and new clients. And so sometimes the existing clients come just to tighten things up, get a little bit more familiar. And that almost always helps a lot. We actually had a client in one of our one-day courses recently who didn't know about a whole angle of, how to improve workflow and do things for sleep. I'm confident that just from sitting in that course, that's another 10, 15 grand just from that one sentence. That was like a moment. Oh my God, I didn't know I could do that. I'll do that on Monday.
Yeah. So tell me a little bit about that. So if let's say someone sees this and they say, you know what, I just want to see how much sleep apnea potential that I've got. All right. So considering the average practice, I want to say, and you'll know this better than I do, I want to say statistically, is it 35 or 45% of the population suffers from some level of sleep apnea? Is that right?
Correct. So if you want to be very conservative, I would drop that to 1 out of 5. So let's just call it 20%. And then assuming that you're going down the team workflow and you're really trying to push this through hygiene, not necessarily grow your sleep by adding new patients,
right.
Grow your sleep with your existing patients.
Right.
Then you got to ask yourself, well, what do you have for hygiene? So let's just say you have 2 hygienists who work each 2 days a week. So you have 4 days of hygiene. Each of them sees 8 patients. So let's just call that 32. Well, 20% of 32 is about 6.5. That's per week. So at the end of 1 month, you are at, let's see, 26 patients, very conservatively. And so of that 26, if you could just convince 3 or 4 of them that they have this deadly disease and they need to treat it, and then your appliance is, let's say, about $3 grand. Now you've added about $9,000 to $12,000 team driven to your bottom line, and you maybe have saved some lives. You maybe have prolonged a heart attack. Maybe have gotten a husband and wife back in the same bed. So it's a rewarding thing to do as well.
Your sound's breaking up just a little bit. I'm not sure if you can tell on your end.
Sorry, is it okay now?
It's a little choppy. I can understand what you're saying, but it's just a little choppy. I'm not sure what's causing it.
I think everything is the same. Check my settings real quick. All right, let's try this. Is it good?
Yeah, let's roll with it.
All right.
Okay, good. Yeah, I would probably that's really conservative, because the way I typically do it is I would say, if you've got, let's say you had 6 patients that were sleep apnea candidates, then let's say that, half of them are going to be CPAP users. right? And so you knock that down to whatever, what is that, 13? And then you say, let's say your treatment acceptance percentage is 50%, then you take 50% of the 13, and now you're at like what, 6.5, right? And so you're looking at 6.5 times whatever your sleep apnea reimbursement is, anywhere from 3.5 to or $2,500 to $3,500 a case. You know, you're talking 18, 20, $22,000 a month. Is that right? No. Would that be a week?
It's about 18, yeah.
Yeah. So, I mean, that's a significant amount of revenue. And I hear a lot of times doctors will say, you know, I need more patients, new patients, new patients. And the reality is, you know, true, if you're going to continue to just do crown and bridge, and that's the only thing that you're going to do, and you're not going to do anything above that, then the only way that you can grow is to either get more of your existing patients to come back more consistently or new patients. You know, that's options 1 and 2. But if you're open to expanding your procedure mix and getting into sleep and TMJ and implant placement and going from posterior or mandibular implants to maxillary or anterior implants, you know, and sinus lifts and some of that kind of stuff, then you start opening up all kinds of potential. And that's without new patients. That's with the patients that are already coming to your practice. So you're meeting more needs and providing more services and able to capitalize without spending the money in marketing. So maybe the exchange would be, you know, here'd be a great question. Where's the return on investment going to be higher? Spending $10,000 in marketing or $10,000 in a continuing education course and getting the credentials that you need to start placing implants or filing medical?
Sure.
Where would that return be higher? From the outside looking in, I'd probably have to say I truly believe that there's only one investment in life that you can make that's guaranteed to give you a return, and it has the highest ROI potential of any other investment that you'll ever make, and that's in yourself. So if you make an investment in continuing education, coaching or information or workflows or systems, you make that investment in yourself, then the return on investment potential there is far greater than getting the billboard or doing a direct mail piece or Google pay-per-click ads. You know?
Yeah, and I would say probably from another way of kind of enforcing what you're saying is in order to market something effectively, you know, a lot of times people will go into marketing and they'll be like, oh, well, I want to, you know, I don't know if this is going to work. I always recommend to people what you should always kind of consider with your marketing is what about if this works unbelievably well? Am I trained enough to do this efficiently, quickly? Does my team know how to handle it? Does the person starting from the first person who picks up the call to the last person on the clinical side, is everybody know what to do? Mm-hmm. Because that's really what you should think of. Is what about if I market something and now I got 100 cases of whatever it is I'm good at? So I personally, for me, I think start with the CE, master it. You know, one of the things myself and Tarun and Dr. Elliott teaches, you know, when you are coming to, let's say, a sleep course, when you get back to the office, the first 5 cases or so should probably come from your own team. You have your own team's mom and dads come in, husbands, spouses. Get familiar, go slow, go through all the paperwork, practice the medical billing, choose the appliance you like, get comfortable with who's going to do what. Then once you've done about 5 or 10 cases in your office, you unleash it on the public.
Yeah. One of the things, some of the feedback that I get occasionally is, well, you know, sleep may be a big deal in Raleigh, North Carolina, or Nashville, Tennessee, but, you know, it's not that big here in Southwest Tennessee or Northwest Georgia. And what my feedback to that always is true, you know, periodontal disease is going to be more prevalent in the Southeast than it is the Northeast, right? There's going to be pockets of the country where certain things are just more common, whether it's, you know, median household income or level of education, oral priority, oral health priority, whatever you want to call it. But the fact of the matter is if someone just started in my business today, right? They just started today's their first day, and they go into a practice to do a PA, okay? They're going to find 10, 15, 20 things that practice needs to address in order to promote growth and profitability or enhance culture. If I go into the same practice, I'm going to find 600 or 700 things. it doesn't mean I'm smarter, and it doesn't mean I'm better. It just means I have more sensory acuity because I've been doing it longer and I have more experience. Does that make sense? Same thing is true if you compare a 50-year-old dentist that's been practicing for 25 years, 20 years,
versus a new graduate,
and a 30-year-old dentist. When that 50-year-old dentist does their comprehensive exam, they're
with the exception of Dr. Richard Sullivan, 30-year-old who's exempt from that.
Yeah, disclaimer there. But if the 50-year-old dentist does a comprehensive exam, he's going to diagnose a $15,000, $20,000 treatment plan, and the young associate dentist is going to diagnose a $2,500 or $3,500 treatment plan, and it's just because they have more sensory acuity. So I would always say make the investment in the education. That's going to enhance your level of sensitivity to listen for what the patient needs, listen to what the patient wants, and understand what opportunities you have with regards to their oral health to meet those needs and wants. Whereas if you don't have that education, they'll say things and they'll do things and they'll ask questions, but you'll never connect the dots because you don't provide that procedure. So for example, if a doctor goes, down to, I think you guys are going to start teaching implant placement here before too long, aren't you? Or are you already doing it?
True does a implant integration course, CBCT and implant, and yes, I believe he is working on doing a implant curriculum as well.
Good. A lot of my guys have gone to down to I think it's the Dominican Republic with Arun Garg,
sure,
and speak very highly of that course. And I know there are various other courses that are great across the country too. But if a doctor, does not place implants now, and then he goes down and he, spends 2 or 3 days learning to place implants, and then he comes back, he's going to see more implant opportunity in his patient base now than he ever knew was there. And it's just because his level of sensitivity is just heightened now, and it's enhanced now because of that education.
It's actually the same thing from people who come to our 1 or 2 day medical billing courses.
Yeah.
They never thought of a certain procedure as medical. They never thought of a certain diagnosis being covered by medical. And then when they hear it and they're seeing examples of it, they're like, oh my God. And then a lot of times what you'll see from either our courses when clients first sign up with us, most offices in the U.S., a significant number of them are out of network with most medical carriers, which means that their statute for timely filing is 1 year in reverse. So a lot of times, like let's say it's May of 2019, you'll see an office sign up to a course or come to something May of 2019, and they start submitting their 2018 claims because they realized how much money was left on the table, how many procedures were billable, how many patients that they could recoup some money for them to continue doing more treatment with them. So, for example, let's say you did a sinus lift and a membrane, back in November. Well, we bill that now. Let's say $1,000 comes out of the patient's policy and pays you. Of course, that's the patient's money. Like they paid you in full. But even with that, you can now tell the patient, "Hey, listen, I can give you your refund. Send you a check, or we still haven't placed that implant up there. Would you like to schedule that and leave this as a credit?" So it helps to kind of continue the patient's overall spectrum of care, being able to get some of their expendable income back through their medical policy.
Yeah, I love that idea, and I teach that. In fact, I coach a lot of my clients to that, and that is this, and that is when you've got the opportunity to credit their account, you want to take advantage of that because that gives you leverage to enroll the next phase of their treatment plan. And if they happen to fall out of recare, that gives you leverage to get them back in. So it's like, or when they cancel or no-show, when they go to cancel an appointment and they call to reschedule, are you absolutely certain you can't make it today? We've got this credit on your account that we can apply towards the cost for today. And so it gives the front desk it puts an additional tool in their toolkit to help retain patients on the schedule, minimize and mitigate cancellations and no-shows, and maximize treatment acceptance and treatment completion in phases 2, 3, 4, 5, 6. Good. So another question popped into my head there while you were speaking, and it was, what was it? Maybe that one will come back to me. I wanted to look at 3D dentist really quick, and what are the courses that you think are not just the most popular, but what if I'm a, a practicing dentist, and let's say I'm relatively limited in terms of my procedure mix, what could I come there and learn? What different courses do you have available?
So we have sleep apnea implementation with Dr. Aaron Elliott. It's a great course if you're unfamiliar with sleep, you don't know too much about it, or you're looking to get started. There's that course with her. There's the medical billing course, which I teach. Then there's some where it's like a little bit of a team effort. We've got some other awesome instructors. So Dr. Richard Sullivan, Sully Sullivan, and myself, we do the 3D sleep course. This is people who are looking to do a digital workflow and want to utilize their CBCT and their CEREC in doing sleep. So a little bit different than Aaron's course, or Dr. Elliott's course. And then we also have a implant integration course. That's Tarun and Dr. John Pashasnik, JP we call him. And that's for, people who are really wanting to learn a predictable system or workflow, using the systems they have in terms of the CBCT and the CEREC and the various guides and planning and all that. And then there's Tarun also has a dentulist course that that's what we call it. That's for people who want to do those all-in-4, all-in-6 hybrid cases. And those are $30,000 to $50,000 cases, depending on what you charge. So those are fantastic as well. So a little bit of sleep, a little bit of medical billing, implants, and then awesome Dr. Brian Magoo is also part of the team, and he teaches a conscious sedation course, oral sedation course, which I didn't realize until him doing a course or two with 3D dentists, how many dentists are still not doing that, because it's such a no-brainer. I mean, you think billing and implants and sleep is no-brainer. I mean, that's like mega no-brainer.
Yeah.
Because in any office, I can find anxiety-riddled patients. That is a national issue.
Yeah.
Nothing to do with location. It's also in terms of, I formerly was an office manager, John, in my 20s and early 30s at dental offices. Selling something to rid the patient of fear was the easiest close I ever had.
Mm-hmm.
If I was scheduling a patient for, like, let's say a surgery, and I'd be like, hey, do you want, oral conscious sedation, or do you want nitrous or whatever? Sure. And almost virtually didn't care what the cost was. It's just, I want to wake up and I want this thing done, or I want to be very comfortable. So that one's a mind bender. So so that's part of the team as well now too at 3D Dentist.
Yeah, that'd be a great thing. I talk about that often. That would be a great thing to do a study on, because I'm willing to bet if you took a random sample of patients anywhere in the country, that or a random sample of practices that do some level of conscious sedation, IV sedation, and then you take a random sample of practices that do not, I would almost be willing to bet that the practices that provide some level of sedation, their treatment acceptance is 10 to 15% higher than the practices that don't.
I'd say that's a safe bet.
And I'm willing to bet that the retention of the appointments on their schedule is much better, because why? I have a belief that if you take 100 patients, let's say, or let's say that a practice, has, 20% treatment acceptance right now. Okay. They have 100 patients, 80 patients say no, 20 patients say yes. I believe that out of those 80 patients, 80% of those objections that they got, okay, from those 80 patients was time and money, one of those two things. And of the 80% that was time and money objections, I believe that 80% of those objections were actually fear and anxiety. They just called them time and money. And so if you're able to alleviate the fear and the pain and anxiety concern, then all of the patients that are currently using time and money as an excuse not to move forward with treatment now can see their way clear to get treatment completed, because that objection no longer exists. We just don't ask the questions necessary, or the patient's not willing to be as vulnerable as they need to be to say, look, I'm scared of needles going in my mouth. You see what I'm saying? Because I had horrible dental anxiety. I recently completed a clear correct case with Dr. Donnie Dean up in Knoxville. And I remember him sitting down, and this is when I first started my case, and they needed to do IPR. And he sat down, he gloved up, and he was getting ready to do something. I didn't know what he was doing. And my hands started sweating, literally started sweating. And I started to get a little white because I thought I was fixing to get a shot. And I wasn't prepared for it. I wasn't mentally prepared for an injection. I had to stop him. I said, wait a second, am I fixing to get a shot? And he was like, no, you're okay. And I was completely fine then. You know, if I'm going to get a shot, I know if I'm going in to get a filling, I need to work myself up to that over a period of days or a period of weeks. I can't just go in and just unexpectedly, this is about to happen. I don't know. That's past my threshold.
I get it. That was my first experience with sedation. I think it was like the first 5-6 months I was working in dental. The person that needed the sedation the most was a John Harris, in that he was young, incredibly muscular, just this fit, tough guy. And his anxiety, I mean, it was to this day, one of the worst I'd ever seen.
Yeah.
But once we were able to offer him sedation, we did everything. We did all his restorative work, we did SRPs, and that took care of that. And unfortunately, prior dentists of his had not offered that service. This is like 15 years ago, almost. Prior dentists had not offered that service to him. So and it wasn't a financial issue. This man was financially very well off, but because it really wasn't at his previous dentist, he didn't really do the work he was supposed to do. And so he had developed a little bit of gum disease, a little too much caries, that were a little too big, we had to do more aggressive restorative work on him, which all could have been prevented. If his previous dentist had just offered sedation, I'm sure he would have accepted treatment all day and night at his previous dentist. But we were young, we had all the cool stuff, we were able to take care of it.
Yeah, I think the other thing is too, is this is just human nature. And it is, if you want it, you'll ask. And if I need it, you'll tell me. So the dental team thinks, well, if they want it, then they'll ask us because, conscious sedation is listed on our website. So if they want right? And then the patient's thinking that if they have it, they'll tell me, or if I need it, they'll tell me, or if I would benefit from it, they'll tell me. So what happens is the conversation never takes place. And so because it never takes place, it never comes up, and you get objections, and treatment doesn't get completed, and the patient doesn't get, ultimately what they need. So I think communication is another huge area of opportunity, not just from a marketing standpoint, making sure your patients are familiar with everything that you do, but making sure that you have those conversations on an ongoing basis.
Sure.
Cool. So what else with you, man? What's anything new coming up for 3D dentists? Or I know you mentioned implants. I know you've got the Millennial Mastermind that just kicked off, a month or so ago. I was up there for that, had a fantastic time, a lot of great conversations.
I think you came maybe I guess maybe that was the first time they got together, or the second time they got together.
I think it was the first one.
Yeah, Sully and Tarun came up with that. I want to say maybe late 2018, early 2019. So that was pretty cool. And I'm hearing it's going pretty well. And I myself got a 1-day medical billing course, Cleveland, Ohio, in June, Raleigh, North Carolina at 3D Dentist in July, and Kansas City in August. So my summer's already spoken for. Dr. Elliott has a course that you're coming to. June 14th and 15th, is it? I don't have my calendar in front of me. Yeah. So there's that sleep implementation course as well. And then, Tarun's got his integration implant stuff. So all of us are clicking and firing away.
Yeah, cool, man. The question that came up earlier that I forgot that I wanted to circle back to was, what would you say to the doctor that's hesitant to pull the trigger on CBCT because of cost? I know what the answer is, but I ask this question just about everybody that I do these things with, so I can get multiple people saying the same thing. But what would you say to the guy that's hesitant to pull the trigger on CBCT because of cost?
I hope mine's not too different, because then I'm going to be the one weirdo that said the different thing. So in terms of cost, so there's a couple things. One is, let's just call the cost, quote, what's on the actual statement. Let's call it $2,500 a month. Well, if you then take the depreciation that you're going to get off of, Section 179 or some of the other tax breaks, the real payment is not $2,500. So the first thing would be to ask your CPA, well, what benefit I'm going to get, because there's going to be a benefit. So the real cost might be like, let's say $1,500 or $1,800, something like that, after depreciation. Let's just say it's $2,500. And there's a million different ways you could look at it. So let's say you're a dentist and you're like, you know what, I want to do cone beam for free. Okay, fine. So you're telling me you can't do one more sinus lift a month? You're telling me you can't do 2 more implants a month to cover the machine? If you are willing to charge for the CBCT, set some kind of ridiculous fee. Set something like your panel filler. Let's call that $100. If you agree to do CBCT as part of your FMX, as in you're going to do 4 biwings, maybe a couple PAs, as an alternative to your 18 two-dimensional x-rays that you do in your FMX, and you, let's say, call that $100, well, then the question becomes, well, how many FMXs do you do per month? And take that number, multiply by 100. So let's say you get 30 new patients a month, then you get about 10, 15, 20 recalls through hygiene. That's about 45, 50 patients. And so if your x-ray package is about $100, well, that's $5,000. So again, covers the cost of the machine. So there's a lot of different ways of covering that angle of cost. In my experience, and I'm not saying this because I speak or whatever nationally for certain companies, but there's few things I've seen be as profitable, or if you want to word it, as bringing in as much profit as CBCT. Like, as an example, in order for CEREC to really make you money or save you money or whatever, you have to feed it crowns. As in, you have to find treatment, put the treatment in there, and get the treatment done, proposal, and then the crown. Whereas with cone beam provides you the findings, and then you do what you want with those findings. If you can do your own endo, if you can do your own retreats, if you can do your own osseous, if you can do your own implants, if you do your own, that's all in your scope. And that machine really makes you see it. And more importantly, I think something that a lot of people don't talk about with CBCT is, I think, especially as somebody who was a former office manager, in my day, technology was different. We had intraoral picks and things like that. I would use them as part of my treatment planning. I think cone beam is amazing for case acceptance. When you could throw somebody's skull up on the screen, rotate it around, show you do the surgery, plan a surgery maybe in front of them if it's pretty straightforward, so that they know why they're paying you for that implant. I think that's a huge, powerful communication tool.
Yes, it is.
Acceptance.
Yeah, it's true.
That's my take on it. I don't. That is one of those things I don't really see a cost on, just because I could probably come up with 20 different ways to cover it.
Yeah. It's tremendous for treatment acceptance. And I think the other thing it does is I think it would certainly give me as a dental patient a certain peace of mind, knowing that the doctor that's planning my implant case or planning my, crown or whatever, has advanced technology that I haven't seen in other practices before. So it would give me a certain peace of mind and a certain our number one human need, certainty. It would give me more certainty. I talk about.
I would agree with you as just like, let's say, quote, layman to dentistry. The funny thing is, if you talk to reps, you talk to people like me and you, people who are in the industry, we won't even go to a dentist that doesn't have CBCT. Because we just find it so bizarre not to have, you know what I mean?
Mm-hmm.
So look at the behavior of industry insiders, people who work in the industry, what kind of dentist they would go to. That should tell you a lot. So if I was a friend of yours or a relative of yours and I wasn't in dental and you said something like that to me, like, hey, this is how it goes, I'd be like, okay, well, that's how it goes. and I would accept it as the standard norm. So that really just shows you kind of what direction dentistry is going to. And I mean this for those who maybe aren't into that, haven't adopted technology yet. It's becoming almost on a daily basis so commonplace and so normal that you really don't want to miss out.
Mm-hmm.
Hey, I just noticed your clock says 5:30. Why is that?
It's only right twice a day. I've been spending so much on the road. But if you also notice, the plant right here is dead. It's been dead for about 3 years. I don't spend enough time in my office to worry about that clock. I try to spend too much time on the road, and I bought that plant with the expectation. I got about 5 of them in my house. I bought those plants with the expectation that I would be here to water them, and they would thrive and live and give off oxygen, and the oxygen in my house would be more pure. And within 3 months, they were all dead. I haven't taken the time to replace them. So,
you know what? At least that's just a pure outright failure, which is sometimes more acceptable than what. The reason I was 3 or 4 minutes late to you this morning was I was outside about 30 minutes before this call, and I'm very attentive to my garden, like water it, take care of it, whatever. And it had been some time deer hadn't really come there, and part of the reason is because and maybe I did get a little lazy the last 2-3 weeks. I don't know. But anyways, I wake up and I look up I have this little hill, and my apple tree was obliterated. Like they left maybe like 5 or 6 leaves on it. So I don't know if they murdered this tree and cover with just those 5 or 6 leaves and come back to life. But I had some tomatoes growing, and not only did they eat the leaves, they even ate the tomatoes.
Was it deer?
What's that?
Was it deer? What ate them?
Oh, it's got to be deer. I mean, just the size of the bite marks and things like that. So I'm real angry at myself because more or less I was almost on top of it, minus the 1% where I forgot to maybe put some repellent on the last 2-3 weeks. Because, I can't remember. The bottle says, the repellent lasts a month. That's a lie, John. It lasts like 6 or 7 days, dude. You got to do it every week.
Well, I think an out-of-state license in Georgia is only about $220. So around September, when bow season opens up, I'll be happy to come down there and take care of that.
Dude, oh my God. Hey, bro, we have plenty of room in the house. Spend the night here. Please feel free to do whatever you need to do.
Well, man, I appreciate your time today. I've enjoyed it.
Appreciate you, buddy. Thank you.
I'm coming down to Atlanta on Wednesday. We've got a Training University Session 1 at the Georgia Club if you want to come join us Thursday and Friday. And then when we finish up Friday, I'm headed to the beach for a nice, relaxing, long weekend.
But I'd love to see you, man. Either Wednesday night or Thursday night, we'll go out.
Yep, I'll catch you. I'll catch you one of those evenings, either Wednesday or Thursday. We'll hook up. We'll grab. We'll go get. Was it omakase?
Yeah, if you're up for it, let's do it.
I'm always up for it, man. Sushi's right down my. As long as my coach gives me the go ahead, I can't eat anything he doesn't let me eat. So I have to touch base with him. I'm 21 weeks out right now, so I don't have as much flexibility in my diet. But whatever it is, we'll hook up when I get down there, and we'll get dinner and have a good time.
Sounds good, John. Thank you so much for this morning.
Yes, sir. I appreciate you.
Take care.
All right, see you.